Are you providing equal care or equitable care? Do you know the difference? When your agency performs quality improvement projects, do they focus on the intervention or the outcome? Do you pay attention to the disparities that exist within your community? Do you fully understand how those disparities affect your outcomes? Let me give you an example of what I mean. Let's say you want to increase cardiac arrest survival in your community. Looking at your community as a whole, your bystander CPR rates are 50%. You decide to start offering free CPR courses at the local high school. After a year of doing this, your bystander CPR rates have risen to 60%. Great. This looks like a success on paper, right? But where did you go wrong? Well, you may have provided an equal opportunity intervention for anyone to receive CPR training, but you failed to provide an equitable solution and inadvertently worsened the disparity of care provided in your community. You failed to realize that not everybody starts from the same starting point. The work needed to get someone across the finish line is going to be different for each individual and is often due to factors they didn't choose to begin with. You see, the CPR classes were only offered in English, and they were conducted at the high school in the higher density and higher socioeconomic neighborhood. So those who were most likely to take the class were English-speaking participants who lived near the high school. In addition, the mannequins used for CPR were all male mannequins, and the course did nothing to address the mental barriers to initiating CPR in a female patient. So although your bystander CPR rates have increased as a whole, if you were to break your numbers down by race, native language, geographic location, and sex, you would find that bystander CPR rates increase for only English-speaking male patients in the neighborhoods surrounding the high school, far more than any other demographic. You fail to recognize that the solutions for increasing bystander CPR in women or in non-English speakers or in lower socioeconomic classes or even the rural areas of your community would be unique due to the differences in inherent barriers that exist between these different demographics. We're all trying to get to the same finish line, increase cardiac arrest survival, but we have to realize that the journey to obtain this outcome is not one size fits all for our patients. The goal is not to provide equal care. Equal care gets us the same distance from the point we're starting from. Unfortunately, we're all starting from different points on the course with different obstacles in our way. So with this approach, some will get closer to the finish line than others. Instead, we need to provide equitable care, recognizing these differences and working to get everyone across the finish line to increase cardiac arrest survival for all, not just for some. Today's guest, Ritu Sani from the EMS Show podcast, is going to help us dive deeper into this topic.
Here you on it. Here on it. Okay, you're clear. Stand by for your bay. I'm clear, number 2. Go ahead.
Okay.
Yeah, just for a little bit.
Yeah, so he's here helping us.
He had to go to work. Sure. He mysteriously disappeared, and now I showed up.
Yes.
And it's not at all. It's not at all like Chris to just barge in.
No, yeah, not. It's just not in my character.
Never happened.
No. Absolutely, very quiet, soft-spoken, in the background kind of guy. Exactly. Yeah.
Yeah, actually, last year that was pretty much what we did was the exercise, but the exercise was meant to sort of demonstrate that everybody's race is not the same. And when you talk about equity and equitable outcomes in care, you want to focus on outcome or the finish line instead of the individual kind of topics that you do or things you do. What we did last year was just had everybody stand up one side of the room, and then I had them take steps forward and backwards based on just things that were mostly out of their control. Like I said, take 5 steps forward if you were born in the Northeast, take 2 steps back if you're wearing tennis shoes today, just things that people didn't think would have an impact. And we did it back and forth. And then at the end, what you end up with is a group of people that are spread out. Some people are behind the start finish line. Other people are almost at the end. And then you ask people, we're going to run a race now, go. Whose journey does everybody have the same journey? Does everybody's journey require the same amount of effort? Do some people require assistance to make their journey? Those sorts of things. And again, the focus being on, if you look at the finish line as a positive healthcare outcome, we want all of our patients, we want all of our community to have a good healthcare outcome. We just need to recognize that the length of that journey, or we were doing it in a ballroom, so some folks had like a straight line and other people had to go around like 7 tables. Their journey just is going to be different. And a lot of the reasons why the journey was different was because of factors that weren't in their control.
And that brings up the difference between equality and equity, which I thought was a really good point. You did a really good job of explaining that and bringing that out.
The key is you want to be outcome focused, outcome driven, just like any other quality improvement task that you look at as an EMS medical director. But when we look at equality, let's say we want to improve cardiac arrest outcomes and we decide we want to do AEDs, say. So an equal intervention would be to buy a bunch of AEDs and just distribute them in the community sort of relatively equally. You might improve in your community as a whole, you might improve outcome. But at the end of the day, if you start looking at different communities, you will have had a different impact in each community. So the equity lens or the equity solution is to say, I want to improve cardiac arrest survival in my entire community. What are the different drivers to that? So it might be AEDs might be one thing, but I am willing to bet that if you start breaking down your own data on cardiac arrest survival, you will find that there are certain communities with much less bystander CPR rates. And so if you're going to have an equitable solution, then you need to pivot to go, well, in this community, we have 70% bystander CPR here, but we only have 30% here. That's got to be the fix there. So the solution is the same for everybody. And equitable is we try to find different solutions that end up with the same result for everybody.
You highlighted there the importance of measure and improve.
Yeah.
And I think when you start talking about, well, first off, is care equitable in emergency medicine?
No. We wouldn't be doing this talk.
Right.
Yeah.
And people are people, systems are systems. Care is not equitable. If you look at it in emergency medicine, if you look at it EMS, repeatedly, there have been studies that showed that care is not equitable. Probably the 2 most common areas that are looked at are pain management. So there's a ton of emergency medicine data that shows that there is a difference in pain management based on race. There's now the similar data in EMS. Jamie Kennel did that work as his PhD thesis. He's also done that work in chest pain, finding that there's a difference in management of chest pain based on race. There's a lot of data out there that shows that cardiac arrest survival rate is different based on race. We know that cardiac arrest survival rate is different based on urban, rural, and suburban environments. So when we talk about equity, it's not just race. It can be socioeconomic class. It can be urban, rural. We found in our own system, we're publishing a paper that shows that the time to defibrillation in female cardiac arrest patients is about 1 minute longer than it is in male patients, as an example.
So, Ritu, I've got a bit of a question. So some statistics lately have showed that EMS itself is diversifying. The people that make up the responders is diversifying. Do you think over time, as we see that diversity increase, is that going to help address some of the disparities in our community?
I think that is one solution that is important. I think that in the public safety world, people feel more comfortable with people that look like them, right? Whether it's fire or police or EMS. Having a workforce that reflects your community, I think, is an important piece. but it's also going to be difficult. The guys from New Orleans, Titus and can't remember. We did a podcast with them, and their workforce looks like New Orleans, and I think that's just a huge difference. But I think that's part of it. But I also think that the really important methodology or solution is you got to ask the question.
Right.
You gotta look at your own data. And, I preach that. We don't do it as much as I would like to, because looking at data takes some time, energy, money, effort. But we've done some little things here and there. But I think that's fundamentally the solution. Because I think that you have to understand that a lot of inequity of care comes from systemic factors. So even if the workforce looked exactly like the patient population, there are potentially systemic factors that make it difficult. So I think you have to ask the question of your own data. And then if you find a difference in outcome, you attack it like any other data or outcome issue you would have in EMS.
So for someone who's never looked at that before, how would you recommend starting to look at equitable care?
One would be to just look up Jamie Kennel's work, just look up other papers and stuff that's out there on equity of care and see what other people have published. The 3 places I think that are easy to look at are going to be pain management and trauma, chest pain management and cardiac arrest, survival. And then nowadays, if you have any of the widely available PCR systems, whether it's ESO or Image Trend or some of the newer ones, everybody allows you to slice and dice your data much easier than they used to, and run that data by race, gender. I think some of them allow you to do it by socioeconomic track, those sorts of things, and just see if there's a difference. And if there isn't, God bless. Yeah. That's awesome.
Yeah.
Right.
Let's say you find a difference. How do you approach your crews about that? Because I think everybody likes to think, well, I'm not racist. You said this in your talk. People are like, well, I'm not racist. That's not me. I don't do that.
Right.
Yeah.
Right. And that's what happened. The paper that I talked about, pain management, that Jamie wrote, that was data from our system. And that paper got play in the local press. And so a lot of our providers were really upset by it. And Chris talked about just culture yesterday. It's a just culture approach to everything. And so the idea isn't, you look at these disparities in data, you all are racist. You're so mean you just ask the question, look at these outcomes and what do you think is driving it?
Right.
And use all of the same techniques you would use if you found that you had a sudden drop in your intubation success rate, or if you found that cardiac arrest survival in a certain community was dropping. What would you do to intervene there? You would, whether formally creating a driver diagram, or you would brainstorm sort of what are the possible causes, what are some possible solutions, and then do a classic plan, do, study, act cycle. To me, the least judgmental way to do it is to approach it like any other quality improvement problem. And that's what the National Association of EMS Physicians just came out with a position paper around this. And it's funny because when you read the paper, it's like a mini primer on quality improvement, because it's really like just use standard quality improvement techniques to try to improve your patient outcomes. I do think that at some point there's got to be a period of introspection. I have news for most people. You are a racist, because we all judge people sort of blindly and without even knowing it. It's called implicit bias. And taking a look at yourself, I know I've had to do work on uncovering where I have implicit biases. And I've had some great friends who drove me in that direction, whether or not I wanted to go. And so I think some of that work has to be done. But I do think that the fundamental approach can't be blame. If you're patient outcome driven and everything you do as an organization, then this fits with that philosophy. And to me, that's what you have to be as an EMS agency, is patient outcome driven.
Yeah, I like that. And focusing, again, going back to the equity on the patient outcome itself.
Right.
Not the intervention, not focusing on what the intervention is, but is it affecting the outcome?
Right.
Okay.
You may find that, yeah, exactly. I mean, again, bystander compressions is a really classic one, because there's a lot of data that there are different bystander compression rates in different ethnic groups. And, one of the ones that's just you're never going to overcome is that in non-English speakers, the time it takes for the 911 dispatcher to recognize a no-go is going to be longer. So you just have to know that. But having appropriate language lines and all that stuff can help. Having Spanish-speaking people in your dispatch center is a huge benefit. But sometimes there are just structural abnormalities that you're never going to overcome, but at least you have to recognize that.
Thank you so much.
Thanks,
Dr. Ritu Sani of the EMS Show podcast and Chris Fingston of EMS.
Chris, that was like the quietest you've ever been.
I know. Well, he was so well
coming
prepared.
on and sitting here and listening and not saying a thing.
I had one question in there. I had one question. Yeah, quiet's not my forte, but I managed it.
Yeah,
so there we
strong
go.
work.
So perfect.
He's still, I used to be his medical director, so he's still.
I'm still a gun shy.
Yeah.
I still gotta mind my P's and Q's. That's what we called him back in the day. It was a Ritu the Hammer Sani.
Yeah.
That was it.
That's that whole just culture. They called me the Hammer.
Yeah, absolutely. The Hammer of just culture.